Short of time, I think I will go through this presentation very fast. Can you just have that presentation, sir? Yeah. These are my, what is important is FLACS in complicated situations, white cataracts, hard brown. How many of you do FLACS? Femto laser assisted cataract surgery? No, okay. Posterior polar cataracts, subluxatory cataracts, Fuchs endothelial dystrophy, NHNT, neither here nor there, cataracts are very good, shallow AC. So you all know that artificial intelligence is definitely catching up in a big way. These are the machines which are available. I'm using the catalyst, I don't have any financial interest. The simple thing is about the FLACS is that because of the cost, everybody is not doing. Otherwise, the versatility is something which is akin to compared to Sachin and Dhoni. Dhoni is good in all formats, Sachin is good only in one format. So these are all the FLACS, merits of FLACS. But one of the most important things is safety, precision, accuracy, predictability, faster recovery, bladeless technology. So let us see some scenarios, the hard brown cataracts, how it is there. I do FLACS for these patients unless the patient cannot afford, but these are all the difficult problems which if we do a manual phaco, there is a possibility of doing excess phaco energy. You can get a corneal burn, and along with the corneal burn, you can have also this thing, the corneal edema, and also cystoid macular edema, and something like a TAS, which is there on the surface of the eyeball. So what we do is combine the technology with the technique, and I have the Mohan Rajan chopper. I don't have any financial interest. Again, it's gone. What's the problem? Why it's going on? So this chopper, what we are using is something which is, I'll just show you one regular manual phaco and how different it is. And this is a manual phaco wherein you can see here I'm doing a capsulorhexis with the trypan blue because I want to make sure the capsulorhexis is a little larger size. So you continue with the phaco, and this is a manual phaco, it's a very hard brown cataract, supra hard cataracts. So again, in a FLACS you can see here this is a grade 3 cataract, grade 3 to 4 cataracts. I'm sorry, there's a problem in the, what's the problem? Video. Okay, I'll probably stop here and we'll take some questions. Any questions from the audience?
Yeah, can I?
Yeah, please.
Yeah, actually this question was for Dr. Sujata, but I think anyone can answer.
You can proceed with the question.
Yeah. So we saw that in two cases she presented, there was a pseudo exfoliation and there was a dislocated lens after 7 or 8 years. So in PXF cases, can we think that we can put a CTR or a capsular tension ring in the first place?
Amar sir, you would like to take this?
When we have a subluxed IOL.
No, before, even if it is not there in a PXF regular case.
Yeah, I tell you frankly, these cases are all progressive conditions. I straight away do a glue dial. By putting the CTR, I've seen 10 years later, no, CTR will lie on the retina with the IOL itself. So if you have a traumatic case, yes, you can do a CTR. Because that's not a progressive condition. But Marfan's, all these type of conditions, pseudo-exfoliation, these are progressive conditions. It's not going to be there for some time only. So my personal suggestion is, in such cases, after doing everything, fix the glue dial. You'll be always safe. These patients will be like that for life. So one small trick, I'll come back. One small trick I want to tell you also, if you're doing a glue dial, if the eye is more than 11 millimeters, You want to come more anterior, remember that, because I want more haptic externalized. You will hit the iris, so make a small iridectomy in the area of the scleral flaps, so that when you come anteriorly, you will not hit the iris, you go through the iridectomy. Next question, you were saying something just now?
Yeah, even if there is no phacodonesis also, we can think of doing a,
If there is no phacodonesis, if it's a normal cataract, then you can do, no need of doing anything, put normal IOL inside.
yeah, but the cases that were presented, I think.
Yeah, if there is phacodonesis, 100% go for a glued IOL, because they are progressive conditions. They will not remain like that. So if you put a CTR, what will happen is you might get away now. 6 months later, 1 year later, 2 years later, the patient will have some dislocation, definitely. And then again, you will have to go back for surgery.
And removal of CTR is very tricky. Even from the ciliary body region, if the IOL bag complex decenters, removal of CTR is very, very tricky. It slips.
What's the next question?
If I'm allowed, can I ask?
Please ask 100 questions. Who's the next speaker here? Vasavada group, no? Don't worry. You can continue. Madam, don't worry.
So in this iris, posterior fixated iris claw lenses, the difficulty which I face is, I think the first haptic, the first tucking is done properly, but when I'm doing the second tucking, the second opposite tucking, then I have problem because the AC collapses.
That's why I said do glued IOL, na? I will answer.
I think one thing is you have to use viscoelastics, but not too much. When you're doing the second haptic, no, I just use it between the iris and the lens. So we just need enough space for you to grab it and go underneath it.
It's a big wound, so the minute you enter, it collapses. And
Yeah,
then
so second take, what we have learned is the first haptic tuck should be from a non-dominant hand. So the first haptic tuck you do with a non-dominant hand. Okay, then the second haptic tuck you have more control. Normally the mistake what we do is we do for right hand first. If you are a right-handed person, then the left hand always struggles because you don't have a grip, the IOL sometimes slips. So do the left hand first. And then same with glued IOL also. Once you want to externalize the haptic, do the left hand first. It's little easier for you because the second haptic removal is always, taking out is always slightly challenging.
One small thing I'll just mention before we close up because of the Vasa.
Amar, you can talk. I'm just showing some videos because this just to show you how the femtocataract works. You can see how the pre-chop is already there, the rexus is already there, and the very fact that the gas bubbles are coming from the posterior thing, it means that the cut has gone all the way down. So again, another patient can see here how easy it is for you when you do a catalyst because it makes the life easy. You can see the EPT is only normally 30 seconds in such cases, brown, black cataracts, and that is the advantage. Another big advantage is, quickly I will go through this, the black cataracts and also the cornea gutata. It's a very useful technique as well because you use less phaco energy. And more importantly, in subluxated cataracts, I'm going to show you this thing wherein you can see here how the subluxated cataracts, it's and very mature white cataracts. How many of you have had this Argentina FLACS sign problem? Many of us have had. So this is I think, absolute technique, foolproof technique for femtocataract. You can see here how the femtocataract works very well without any Argentina FLACS. And of course, other areas like the posterior polar cataract and the softer cataracts also, patients who are coming with 6/9, 6/6 vision also use, because I want to make sure that I am on the safer. I tell the patients that safety is more important. And when I do manual, I do 100%, I give 150% safety when you have the catalyst. So if we have access to catalyst, I think you should do that. The only problem hindering is the cost. I'm sorry, Amar, you can go ahead with the discussion. Sorry.
We should close, I think, now because the Vasavada group is there, and I tell you what, they have knives also.
Give one last
come
message.
to all of us with knives. Thank you very much, everyone. I'd like to thank Mohan Rajan, Sujata Mohan for this lovely course, and most important, all of you. Thank you very much. We can take it offline, any questions. But